This presentation will discuss the evaluation and treatment of proximal junctional kyphosis. Proximal junctional kyphosis, or PJK, is a well-recognized complication in patients undergoing long-segment spinal fusion. The goal of this presentation is to understand the definition and risk factors for PJK, recognize prevention strategies for PJK, review the principles of treatment, and provide relevant case examples. PJK is defined as abnormal kyphosis above the uppermost instrumented vertebra, or UIV. It is measured by the sagittal Cobb angle between the inferior end plate of the UIV and superior end plate of 2 levels above the UIV, or UIV plus 2. The exact definition of PJK varies in the literature, but most agree that the threshold for PJK is 10 degrees. It is also important to realize that most cases occur early in the postoperative period, with approximately 2/3 in the first 3 months and 80% by 18 months. There are many risk factors for the development of PJK, which can be thought of as those inherent to the patient and those related to surgery. Patient-related factors include old age, higher body mass index, osteopenia or osteoporosis, higher pelvic incidence, and greater sagittal imbalance. Surgical factors include disruption of the posterior ligamentous complex, a greater magnitude of deformity correction, extension of a long segment fusion into the sacrum or pelvis, and instrumentation failure at the upper levels. There have been several attempts to classify PJK, however it likely represents a spectrum of disorders, ranging from asymptomatic radiographic kyphosis to severe symptomatic kyphosis causing neurologic deficit. 2 formal classification schemes include the Bochy-Adjei classification and Hart ISSG PJK severity scale. The first classification system includes the failure mechanism, degree of PJK, and presence of spondylolisthesis at the UIV. The failure mechanisms are classified as ligamentous, bony, or at the implant-bone interface. Degrees of PJK are classified as 10 to 14, 15 to 19, or greater than 20. The Hart ISSG PJK severity scale includes scores for neurologic deficit, pain, instrumentation failure, the degree of kyphosis, the presence of a fracture at the upper levels, and the region of the UIV. There are many strategies used to prevent PJK, each with variable success. Soft tissue preservation is important to avoid inadvertent damage to adjacent muscle, ligament, and the superior facet. UIV selection is important to prevent excessive biomechanical stress on the construct. This includes avoiding the termination of a long segment fusion at the apex of thoracic kyphosis. Hook fixation is a useful adjunct that minimizes soft tissue dissection at the uppermost levels and provides a smoother transition from mobile to rigid segments. Cement augmentation can minimize the risk of compression fractures at the UIV, which is particularly helpful for constructs terminating in the lower thoracic spine, since this is a common mechanism of failure at that location. Ligament augmentation has the potential to reinforce the posterior tension band and ligamentous complex, while also easing the transition from mobile to rigid segments. Terminal rod contouring is also important to avoid excessive load forces at the top of the construct. The evaluation of PJK patients begins with a thorough clinical assessment, including pain and disability, as well as checking for a recent history of mechanical falls. A thorough neurologic exam should be performed, including an assessment of the patient's posture. Imaging should include standing X-rays, CT scan, and MRI. In general, asymptomatic PJK can be observed, while symptomatic PJK warrants surgical treatment. The goals of surgery are to correct focal kyphosis, restore sagittal alignment, and decompress neural elements. In patients who do not require urgent treatment, one should consider medical optimization of bone mineral density when possible. Most surgery for the treatment of PJK involves extending the fusion past the apex of kyphosis. The focal kyphosis can typically be corrected with low-grade osteotomies, such as partial or complete facetectomies, in cases of mild and moderate deformities. Severe, rigid deformities may require a 3-column osteotomy. When constructs are extended into the cervical spine, we recommend careful consideration of the UIV and the use of cervical pedicle screws. In certain cases, an anterior cervical discectomy infusion, or ACDF, can be used as an adjunct to provide anterior column support. Additionally, in cases with limited or poor fixation, the construct can be extended to C2 to ensure strong proximal fixation. Our first example is a 59-year-old woman who presented with severe back and leg pain after an L4-5 instrumented fusion at an outside institution. Standing X-rays demonstrated iatrogenic flat back with sagittal imbalance, shown in panel A. The patient underwent a T10 to pelvis instrumented fusion with L4 PSO, with results shown in panel B. She tolerated this procedure well, but presented 4 months later after a mechanical fall with pain, leg weakness, and evidence of PJK, shown in panel C. Note the proximal junctional angle of 28 degrees. An MRI showed severe stenosis with spinal cord compression, shown in panel D. The patient was taken for an extension of fusion to T4, which included a T9 corpectomy with cage reconstruction, shown in panel E. Our second example is a 61-year-old woman with prior lumbar fusion who was referred to our center with a diagnosis of PJK, shown in panel A. She underwent an extension of fusion to T4 with pelvic fixation and an L1 PSO, shown in panel B. She initially tolerated this procedure well, but developed PJK with 47 degrees of kyphosis at 1 year, shown in panel C. She underwent an extension of fusion to C5 with a T4 PSO, shown in panel D, but unfortunately suffered a mechanical fall during recovery 2 months later. Subsequent imaging demonstrated hardware failure with PJK, shown in panel E. She was taken back to the operating room for an extension of her fusion to C2 and was doing well 4 years after surgery. In summary, PJK is defined as more than 10 degrees of kyphosis, measured by the sagittal Cobb angle between the UIV and UIV plus 2. It is a spectrum of disorders ranging from asymptomatic radiographic kyphosis to severe kyphosis with pain, disability, instrumentation failure, and neurologic deficit. Risk factors for the development of PJK include old age, obesity, osteopenia and osteoporosis, disruption of the posterior ligamentous complex, and the magnitude of deformity correction. Importantly, most cases occur relatively early in the postoperative course. Prevention strategies include preservation of soft tissue at the upper levels, careful selection of the UIV, hook fixation at the UIV, cement augmentation, ligament augmentation, and careful terminal rod contouring. Asymptomatic PJK can be monitored, while severe, symptomatic cases warrant surgical treatment. Preoperative optimization of bone mineral density should be considered when possible. Surgical treatment typically involves extension of fusion with correction of kyphosis and decompression of neural elements. Osteotomies are often required to correct the kyphosis, and this may involve 3-column osteotomies in cases of severe rigid deformities. Thank you.